Welcome back to Metabolic Mind, where we're sharing information and resources at the intersection of metabolic health and mental health. I'm Dr. Brett Scher. Today, we're going to talk about a specific study that recently came out looking at ketogenic diets in pediatric epilepsy. Now, here's why this is so important, though, because they talk about different versions of the ketogenic diet, their efficacy in pediatric epilepsy, and their adverse effects. And I want to talk about that and tie it into what this might mean for using ketogenic diets to treat mental illness, the specific types of ketogenic diets, and potential adverse effects. And I'm going to be joined by Beth Zupec-Kania, an expert in a registered dietitian and expert in ketogenic diets for treating both epilepsy and mental illness, who's been involved in the epilepsy world for about 30 years now. So she has so much experience and knowledge, and she's really going to help us with this. So first, we're going to talk about a little bit of the specifics of the diet, of the trial. Then we're going to talk about why that's important, and give an overview of the different types of keto diets. And then we're going to hear from Beth, and then we'll wrap it up to see if we can come to some conclusion about why this is important and what it might mean for you. Now, first, please remember our channel is for informational purposes only. We're not providing individual or group medical or healthcare advice, and we're not establishing a doctor-patient relationship. The interventions we discuss, specifically ketogenic diets to treat either epilepsy or mental illness, is a powerful medical intervention that changes your body's physiology. So definitely discuss this with your physician and your healthcare team. Do not do it on your own. It can be dangerous if done without proper supervision. So please take this information and share it with your clinicians and decide if it's right for you, but do not try this on your own. All right, so the study is called Efficacy and Safety of Dietary Therapies for Childhood Drug-Resistant Epilepsy, a systematic review and network meta-analysis, and it was published in JAMA Pediatrics, and it comes from a group out of India. And basically what they did was they looked at a number of different studies that looked at using versions of a ketogenic diet to treat pediatric epilepsy, and they combined them. So it's called a meta-analysis. You take all the data from the individual studies and combine them to see in aggregate what they find. And it's got strengths and weaknesses, right? You can take smaller studies and increase the statistical power by combining them. But each study also is a little bit different inclusion criteria, exclusion criteria, different interventions, different outcomes. So that kind of sometimes can increase what's called the heterogeneity and weaken the study a little bit. So just with that little caveat, but they do tend to be fairly high quality of evidence. Now, here's what's interesting. First, we got to talk about the population, right? The mean age was 4.6-year-olds, right? So they were very young. They were babies, which might not, directly apply if we're talking about adolescents and adults with mental illness. But this is the population that is dealt with most with ketogenic diets and intractable epilepsy. So that's what they focused on. And the mean seizure frequency was 27 per day. I mean, that's imagine the quality of life that these patients have with 27 seizures per day. But to jump to the conclusions, they found some pretty significant results. There was a greater than 50% reduction in seizure frequency in a ketogenic diet, a modified Atkins diet, and a low glycemic index treatment diet. So for the keto diet, it was 44%, modified Atkins, 56%, low glycemic index, 64%. Okay, now, what does all that mean? Well, here's a graph from Beth Zupec-Kania talking about the different types of diets. I guess it's a table, not a graph, but you can see the ketogenic diets are referred to as 4-to-1, 3-to-1, 2-to-1, or 1-to-1, which is the ratio of fat to carbohydrates and protein together. And you can see the traditional 4-to-1 is very low protein at 6.7% and very low carbohydrate at 3.3% and very high fat at 90%. So that's the traditional ketogenic diet and different versions of it with the 3-to-1 and 2-to-1. Then you get the low glycemic index treatment, which is still pretty low carbohydrate at 12%, but higher protein at 28%, and still relatively high fat at 60%. And then the modified Atkins, basically created by Dr. Eric Kossoff and his colleagues at Johns Hopkins, which is still low carbs at around 3 to 6%, and protein around 30% and fat around 65%. Now, all of these diets can produce nutritional ketosis and frequently do. So they're all versions of a ketogenic diet. And that's what can be a little bit confusing that Beth Zupec-Kania is going to help us understand more about in a minute. But then if we look at the study, go back to the study, and greater than 90% reduction in seizure frequency. The ketogenic diet was 20%, modified Atkins 28%, and low glycemic index was 13%. And usual care was only 3%. Now, for this one, the ketogenic diet and modified Atkins statistically did better than the low glycemic index. And same for 100% efficacy. The ketogenic diet, modified Atkins were better than the low glycemic index. But for 50%, they were all the same. And all of them were better than usual care, significantly better than usual care. So it's clear it works, right? We know it works. We have plenty of studies showing that it works. But what I think is interesting about this one is looking at the different variations of the ketogenic diet. And we can see that you don't have to have the traditional 4-to-1 for it to work. And we're going to hear again from Beth a little bit of perspective. But here's the next thing. 7% withdrew. And the paper kind of made a big deal about the adverse effects and with the withdrawals. 7% from the ketogenic diet and modified Atkins diet, which was statistically greater than the usual care and the low glycemic index treatment. But it's interesting to look at the reasons for withdrawal. Because remember, we're dealing with a very young pediatric population. So one of them was parental unhappiness. One of them was food refusal. And then there was also constipation, decreased energy, hunger, abdominal pain, vomiting, right? So there definitely were some adverse effects, but only 7% withdrawing. And what's the withdrawal for medications and what's the risks of surgery? And right, so 7% is actually not that much. So maybe not that big of a deal. All right, so that's the general overview of the study. So now let's hear from Beth Zupec-Kania. Like I said, a registered dietitian with over 30 years of experience using ketogenic diets to treat pediatric epilepsy. So let's hear her perspective and the importance of the different types of keto diets and how she sort of synthesizes this data. Well, Beth, I really appreciate having you back to talk about this study because it is a little bit confusing, some of these terms. They talk about a ketogenic diet, low glycemic index therapy, modified Atkins, and there are different types of keto diet. So you've been involved in treating patients with epilepsy with ketogenic diets for decades. And so can you give us sort of a high level overview of what is the difference between these diets and why is that important?
Yes, so I think it's helpful to talk about the origin of ketogenic diet. So 101 years ago, the classic ketogenic diet was designed, and it was designed in terms of a ratio system of fat to non-fat. And so we call those ratios 4-to-1 and 3-to-1, and the 4 means grams of fat, and the 1 means carb plus protein. So the 4-to-1 would have been the highest fat diet, 90% fat, 3-to-1, 87% fat. So over the years, people have learned to kind of modulate the diet for those patients that have difficulty tolerating it. And in the 1970s, the Mayo Clinic came out with the MCT oil diet, which is even lower in fat, but uses a high percentage of fat from medium chain triglycerides, which we know is a little more ketogenic. And then years later, Johns Hopkins came out with modified Atkins as the diet became more popular, and they realized that, boy, even if you don't follow it so darn closely, you can still have good seizure control. So modified Atkins is quite liberal, in fact, in terms of not measuring foods, which all of the other diets that I just mentioned were very restricted in terms of the amounts of foods being measured in some fashion. And then the low glycemic index treatment is another hybrid diet that's also very liberal. And that came about because the originators of that at Massachusetts General Hospital had a huge waiting list of children waiting to get in to be admitted to start the ketogenic diet, the classic ketogenic diet. And they thought, why, we can't make people wait 3 or 4 months. Let's just start them on something that's very easy, like sugar-free, low glycemic index. And lo and behold, what they found out was that for some of those kids, it worked. And they didn't need to be hospitalized, and some of them barely were in ketosis. So everybody kind of paused when that was published, like, wait a minute. What are we doing here? Do we really need to use the classic keto diet when these other hybrid diets seem to be doing about the same? So we all kind of just got together, and this is part of the consensus guidelines, and said, you know what, let's say we've got all of these therapies and individualize it. Some children need these really high ratio diets, and those tend to be the young children that can be very compliant because there's an adult managing it. Babies, of course, very easy. It's just usually formula for the first year. And then and patients with feeding tubes, right? They don't taste the food. The food is in the form of a formula. It's going down a feeding tube. We can use a high ratio. So that's how we kind of started to separate out, like, let's be very careful about which diet we choose for an individual. And so now there are guidelines that help the professional determine which therapies work best. And it tends to be the younger the patient, the more restrictive the diet, the older the patient, the more loose and liberal the diet.
And that's really helpful to get that historical perspective and understand, one, sort of how the diet evolved, even though it's all still versions of a ketogenic diet. And two, I think it was really helpful to hear you describe the patients we're talking about, babies drinking formula, very ill patients in the hospital with feeding tubes in. And that's important because as we try and relate this to people using a ketogenic diet to treat mental illness, we're talking about a completely different patient population. But the mechanisms still sort of hold true in terms of this connection between seizures and mental illness and the cross mechanisms. So how a ketogenic diet works, which versions of a ketogenic diet works, is still a worthwhile discussion to bridge that gap. So were you surprised to see in this meta-analysis that for greater than 50% seizure reduction, whether it was the 4-to-1 keto, the modified Atkins, the low glycemic index, they were statistically pretty similar in their degree of improvement for people getting more than 50% seizure reduction? Did that surprise you?
It did not surprise me, but again, I think that they judiciously chose the diet for each of those people so that they were successful with it, right?
Good point, that they chose the diet for the person. Yeah, that's a good point. And then on the flip side, though, when we talk about adverse events, they did make a big point to say that the adverse events were higher in the keto diet and the modified Atkins diet. But it was interesting to see, like, some of those were parental unhappiness. That was one adverse event, a reason for withdrawal. Food refusal, that, babies can just be refusing the food or the formula or whatever. And then there was constipation, decreased energy, hunger, abdominal pain, vomiting. But what I found interesting was it was about like a 7% withdrawal rate. And I'm curious what the withdrawal rate is for medications too, right? 7% actually doesn't sound that high. So I wanted to get your perspective on what you thought about the adverse events that they reported.
Yeah, I think it's so complex to do diet studies, as you know, because it's not just diet. We can talk about diet and the type of diet and all of the technicalities of the diet, but then there's compliance to the diet. And there's medications that are on board. And with kids with epilepsy, they're generally on 2 or 3 or more anti-seizure medications, which all have adverse effects. And likely those kids were having those adverse effects before they even went on the diet. And those aren't reported in the studies. They're not asking for those. And it would be very helpful to know, did they have constipation beforehand? In my experience, every single kid has constipation when they're on anti-seizure medications. And that I know that because I do intakes on them. And the family, that's one of the questions on the form. So does the constipation get worse? Maybe, but they already had it prior, and that's revealed. Definitely parents kind of grieve with long use of keto, even short use of keto, because they feel terrible about restricting this child from a joy, a daily joy that they practice 3 or 4 times a day. And that's often, mitigated by mentally preparing the family ahead of time. And also, telling them your child is on this short term. It's only a couple of years of their life. Most kids don't even remember being on the diet. So mentally preparing the parents, which we don't know if they've done that in each of these studies, that's not reported. So we have all these factors, but I think one of the factors that's definitely left out of studies is that they hone in on the adverse effects of the medications. However, they don't really identify, had that been a problem before, A, B, which medications, because I can tell you which medications we're going to see issues with because it's the same medications repeatedly used in children with epilepsy. And yes, they're going to have an adverse effect that probably could be mitigated by lowering the dose or changing something in the therapy.
So just out of curiosity, what are the top, 2 or 3 medications that are on your radar?
Yeah, so one example is topiramate, or brand name Topamax, which is in a class of medications called carbonic anhydrase inhibitors. It's well known that it can cause acidosis, and in combination with a ketogenic diet, that effect can be exacerbated. And how do you mitigate that? You increase fluids for sure, because you have to be able to buffer that acidosis. You can also reduce the dose. Some very experienced neurologists automatically reduce that dose by 25% when they start keto. But no one reports that in these studies that they do that. So that's a very common one. The other one is valproic acid, which is used not only for epilepsy, but used frequently for migraine headache. And I've learned that is a protein-binding medication. And I think any protein-binding medication can have issues with keto. Not sure why, but I just know from working with meds like that they do. But one of the adverse effects is lethargy, right? Sleepiness. And sometimes kids get first more bright and alert, and then they get really, really sleepy, especially if they're on a high dose of valproic acid. Well, you mitigate that by reducing the dose. Or here's the other thing, they might have a carnitine deficiency. And we know that valproic acid needs carnitine because it has fatty acid properties, and fat also uses carnitine. So there's a study that actually shows that children that were carnitine depleted before they were started on keto have a much lower success rate than those that had normal carnitine levels. So, that's an important nutrient. It's a non-essential amino acid, but it's conditionally essential in this example, right?
Yeah, so those are great specific points that people should write down, take to their clinician, share this with their clinicians, so that because most physicians aren't going to know that because you're so deep in, so knowledgeable into this. So, but now I want to ask your opinion, just your hypothesis, because I know there isn't really robust science about this, but taking what we know from the epilepsy world and these various types of ketogenic diets from 4-to-1 to modified Atkins and everything in between, and applying that to the world of psychiatric care and metabolic psychiatry, do you think there would be relatively equal efficacy in treating someone with treatment-resistant bipolar disorder, schizophrenia, schizoaffective disorder, major depression? Do you think whether you use a 4-to-1 or a modified Atkins or a 2-to-1, that the effects should be fairly similar among those, or do you think it will parse out based on intensity of the ketosis and the amount of fat?
Boy, I think that the psychiatric conditions can have really good efficacy on very modified ketogenic diets. I don't think we need to go to the classic ketogenic diet. I don't think we need these high degrees of ketosis. And that's really my experience in working with people. Almost every adult with epilepsy that I've worked with has depression, severe depression, and they get better. And I'm using a very liberal diet with them, often just starting off with something very basic, like getting rid of sugar, not eating any processed foods, which really forces them to think about, I have to go to the grocery store once a week and buy things that are in the produce department and at the meat department, right? Those are the two places that I go for groceries, and of course dairy. And just making those very minor, what seems to be minor in talking about it, major to the individual because it's a major change in their habits. But that alone, I have seen people say they feel so much better. They don't need as much sleep. They wake up in the morning brighter and they get out of bed right away instead of thinking that they just can't get out of bed.
Yeah, it's a very valuable experience to hear, and the impact that nutrition can have. And like you said, it doesn't have to be that 4-to-1. And also, like you said, that 4-to-1 ketogenic diet was not meant to be a long-term diet. I mean, it's very low protein, so it's not sustainable long-term. So that's the important, very, very important perspective you brought up that I want to make sure we emphasize. Well, I think this was really helpful to give the overview of the different types of diets, interactions with medications, how that can affect adverse effects, and how they can all benefit the brain in very different ways, and can help with seizures and potentially help with mental illness as well. So thank you so much for taking the time to share all this with us. It was very helpful. All right, so how do we wrap all this up and tie it up in a neat little bow and say, how does this apply to using ketogenic diets for mental illness, for treating psychiatric symptoms? And I think it's clear based on what we've seen in pediatric epilepsy that it doesn't have to be the strictest of keto diets. We can use sort of the more common nowadays keto diet, which is the modified Atkins diet. And that likely will have the same or similar benefits as more strict keto diets. Now, question is, does the level of ketones matter? And how do you balance that with long-term adherence? Now, those are things that need to be studied and will be studied in the future to see. But I think for someone, trying to interpret a study like this and say, well, what does this mean? Why are the side effects higher? Can I do this? I think the answer is yes. 7% withdrawal is not very high in any type of a study. Drug studies tend to be much higher than that frequently. So 7% withdrawal is not very high. And applying this to an adult population, the withdrawal could be even less because you can, make your own choices. You're not being sort of chosen for you what you're going to eat. You're buying in yourself. And that's just my personal opinion. But I think the take home is, look, the ketogenic diet works on your brain, right? It is a medical intervention that changes your brain's physiology. And whether it's a 4-to-1, whether it's a modified Atkins, it's going to have similar effects. And therefore, we shouldn't be discouraged by thinking, oh, it's only those really extreme keto diets that work. So anyway, that's my assessment of this study. And I'm very grateful to have Beth Zupec-Kania come on to the show and let me interview her to give her perspective as well. I hope this was helpful to give you a little insight. If it was, please click the thumbs up and subscribe, and we'll see you here next time on Metabolic Mind on YouTube. Thanks a lot, everybody.